So, without further ado, thank you very much for your attention, everyone, wherever you are in the world. We're very fortunate this week to have Professor Marco Novelli, who's previously been consultant gastrointestinal pathologist at UCL, and has been recognised, as one of the premier UK gastrointestinal pathologists. Has a worldwide reputation in the area. So we're very fortunate to have his input on colonic polyps. I think, given time constraints, we'll proceed with that, if that's okay, Marco. So over to you.
So you can hear me?
I can hear.
Fantastic. Okay. I'm actually still professor at UCL, which is what you can see here in front of you. So that on the left, top left panel is UCLH, the London big hospital, but UCL is the middle picture at the top there. So I'll talk to you about colonic polyps today for probably about 40 minutes. And if we've got plenty of time at the end, we might talk about polyposis syndromes as well. So what do I want to cover? So let's get this done. Sorry. One second, sorry. Oh, there we go. Okay. You see that still, Richard? You there?
Yes, I can see that. Yep, still here. Yeah, thank you.
Right, got there eventually. So what we want to cover is we're talking about colonic polyps today. So I want to briefly go over the different types of polyps there are in the large intestine. And then I want to go into a little more detail on some of the more difficult areas. One of the areas that's actually quite difficult, I find, is in biopsies, whether it's an adenoma or a hyperplastic polyp. I'll go through a little bit about the biology there and what you can use to help you in that diagnosis sometimes. I want to talk about assessment of dysplasia in adenomas and just finish off talking about pseudo-invasion in adenomas, which is a problem we see in particularly big adenomas of the sigmoid colon. Okay. So these are the polyps I'm going to cover today. Commonest polyp we'll see, of course, will be the adenomatous polyp, so tubular adenoma, tubular villus adenoma, villus adenoma. Then we've got all the different serrated polyp types. So I'll spend a little bit of time talking about hyperplastic polyps, some time talking about sessile serrated lesions and traditional serrated adenoma. And then we'll move on to some of the less common polyps you see, so inflammatory polyps, mucosal leiomyoma, Schwann cell hamartoma, colonic fibroblastic polyp, which used to be called perineuroma, and finish off talking about hamartomatous polyps. And by the way, if anyone's got any questions, please speak or put something in the chat or whatever. So adenomatous polyps. These can be, so you've got nice pictures on the right-hand side of the panel there showing you different types of polyp. Most polyps we see are the little sessile ones, you can see in the top panel there, but we do occasionally see the pedunculated polyps, you can see in the lower panel. They tend to be bigger polyps, and it's the pedunculated ones that you'll often be able to see a stalk and be able to give an assessment of resection completion or not. Generally speaking, polyps less than about 5 millimeters, do not worry about giving resection margins. The clinicians really don't care, they're not interested. It's only the bigger polyps where you can see a stalk, you have to start worrying about whether you can actually comment on whether the polyp's removed or not. So that's what the clinicians see down their endoscopes. What do we see down the microscope? Well, we've got tubular villus, and villus adenomas, depending on the percentage of tubule and villus formation. Totally unreproducible between pathologists. If I remember rightly, the cutoff is meant to be around about 70 or 80%, one or the other, and you go either pure tubular or pure villus. In practice, by far the majority of polyps are going to be small tubular adenomas, and then some tubular villus adenomas, less commonly. And then particularly in the rectum, you'll often see quite big villus adenomas, but they're much, much less common. Similarly with dysplasia, we should be calling more than 90% of our adenomas low-grade dysplasia. I'll go through the criteria in a minute, but it does vary. Again, it's very subjective. If you look at the UK bowel cancer screening programme, I think on average about 5% of polyps will be called high grade. The vast majority are low grade. So if in doubt, try not to overcall high grade because it has big implications for patient management. The important thing about adenomatous polyps is they all are thought to fall within what used to be called the Vogelstein pathway of adenoma carcinoma sequence. So they're the lesion that's due to a mutation in the APC gene. And adenomatous polyps are obviously the polyp that you tend to see particularly in familial adenomatous polyposis, that polyposis syndrome, but it's also the commonest polyp I think we see in the bowel cancer screening program in the UK. So very common to see small tubular adenomas. So this is the Vogelstein model of adenoma to carcinoma, the so-called chromosomal instability pathway. And you can see here in this diagram, which has got a bit more complicated since Vogelstein first described it back in 1990. But you can see you go from normal mucosa, you'll get an APC mutation classically. You then start to develop a little adenoma. That normally gets a KRAS mutation at some point and then moves on eventually to give you a big adenoma. And then between the adenoma and carcinoma stage, you typically get a p53 mutation. That's the adenoma carcinoma sequence, or the chromosomal instability pathway. And that accounts for something like about 70% of all colorectal cancers in the Western world. So most colorectal cancers in the West certainly arise within an adenoma. Other polyp types, so hyperplastic polyps, again, very common. Probably we see less than we probably should because a lot of the time the endoscopists ignore them or just burn them off and don't send them to us. They're usually less than 5 millimeters in diameter. They're usually in the left colon, particularly the rectosigmoid, and they're usually in the middle to old age patient. And you see some nice pictures there of the actual pictures down the scope. I said, generally speaking now, a lot of our endoscopists don't even biopsy these anymore or take them off. They just leave them. So there's the morphology of a hyperplastic polyp. That's there's 3 different subtypes you can see at the bottom there. There's goblet cell rich, microvesicular, and mucin poor. The one I've shown you in the picture there is a microvesicular type of hyperplastic polyp. But to be fair, no one really bothers to subdivide them usually in clinical reporting. The main reason for this subdivision is there is a link with mutations and with potentially the serrated pathway of carcinogenesis, which we'll come on to. But basically, the microvesicular hyperplastic polyps will sometimes show a BRAF mutation, and the goblet cell rich hyperplastic polyps will sometimes show a KRAS mutation, but not always. And up until very recently, these hyperplastic polyps were considered to be entirely benign and were thought just to be non-neoplastic. Given we know some of these now have mutations, they probably are neoplasms, but generally speaking, they're very low risk. They don't normally progress. We're going to contrast this in a minute with sessile serrated lesions, which are a very different beast, and they do go on to give you serrated type cancers. So this is the sessile serrated lesion. Now for many, many years, these were completely missed. The endoscopist didn't pick them up. And that's basically because you'll see probably in the right-hand panel there, you can see on the right side, that polyp, it looks very sort of white, reflective, and a bit mucinous. These polyps are very flat. You typically get them on the folds of the mucosa, and you often get this cap of mucus on top. And so the mucus hides the polyp. And for many, many years, the endoscopists didn't recognize this, and so they ignored them. And so it's only very recently they've started picking up a lot of these. And now the endoscopists are very aware of sessile serrated lesions. They're picking up a lot more. They tend to wash off that mucus and they can see the full lesion and they tend to resect them. These are often quite big. They're often bigger than 10 millimeters. So they go anything from a few millimeters up to sort of 20, 30 millimeters. And because they're so big, the endoscopists will often resect them piecemeal, so cut them bit by bit, so you get multiple pieces of one lesion. Again, this makes assessment of resection not possible. And again, I don't even bother commenting usually. If they send them in multiple pieces, I don't comment on excision. So if I go back to hyperplastic polyp, you'll see these are usually in the rectosigmoid, and they're usually less than 5 millimeters. In contrast, sessile serrated lesions are usually right-sided and classically greater than 10 millimeters, although our endoscopists are now picking up a lot of much smaller polyps. So we do see them at 5 millimeters, we do see them at 3 millimeters. This is what they look like down the microscope, and you can see the reason they're called sessile serrated lesion is because they're very flat and they grow along. They're not polypoid at all normally on the right side, but that must be said, in the sigmoid, and when you do get them in the left colon, they can be quite polypoid. If you look at the actual high power morphology, they have hyperplastic crypts lined by serrated type epithelium. And the important thing here is the serrated epithelium extends into the crypt bases. Now, if I just quickly go back to the hyperplastic polyp, which I should have said when I was there, can you see how these got very nice, tight, sharp crypt bases? And the serration really is the upper half of the crypt out onto the surface. If we now contrast that with sessile serrated lesions, you'll see serrations go right down into the crypt bases. The crypt bases are often quite dilated. So, which again, if I go back to hyperplastic polyp, they tend to be much tighter. And the other thing we see are these inverted T or J-shaped crypts, where you've got this expansion of the base of the crypt. Those are very classical. Now, sessile serrated lesions, when they were first described, first thing, there's lots of different names used. There's lots of arguments about the terminology. There was sessile serrated adenoma, sessile serrated polyp. Some people called the sessile serrated polyps the non-dysplastic ones, and when they got dysplasia, they called them sessile serrated adenoma. But terminology has been dropped. The WHO classification now is sessile serrated lesion, which is what you're looking at here. And when they do go on to get dysplasia, they become sessile serrated lesion with dysplasia. The classification, the diagnosis of sessile serrated lesion was quite complicated previously, but now, following WHO, all you need is one eccentric crypt base. So one of these dilated inverted T or inverted J crypt bases, and you can call it SSL. So there's a comparison of the two. We've got hyperplastic polyp on the right, and we've got the sessile serrated lesion on the left. And of course, it can be difficult sometimes, particularly in small biopsies. Generally speaking, remember, hyperplastic polyp, left colon, small, less than 5 millimeters. Sessile serrated lesions, typically right colon and big. So if in doubt, you can still call hyperplastic polyps in the right colon, but even small hyperplastic polyp-like lesions or serrated polyps with eccentric crypt bases, you should be calling sessile serrated lesion. Now, there was a huge fuss about this diagnosis 10 years ago, but we now see so many of them that people are much less worried about the diagnosis of sessile serrated lesion. So I wouldn't get too twitched about it. If you see funny ectatic crypt bases, then generally favour sessile serrated lesion, particularly in the right colon. Then the third type of serrated polyp is the traditional serrated adenoma. These are much rarer, uncommonly seen, 1 to 3% of adenomas. And again, a bit like the hyperplastic polyp, they're typically seen in the rectosigmoid There's the macroscopic appearance there. This is the microscopic appearance, and these are the classical features. They tend to be very villous, so they're very villiform. And when you look at the cytology, you sometimes wonder, is it dysplastic or not? Now, by definition, if you call something an adenoma, it's dysplastic. And these are dysplastic, but they're often very low-grade dysplasia. So what you see are these very tall pink cells, basically. So tall columnar cells with a nuclei often at the base, small, quite regular nuclei. And the other really helpful feature are these so-called ectopic crypts, which is probably best seen in the panel on the right-hand side with the, just towards the middle there, you can see what looks like a little crypt. If you do a proliferation marker on these polyps, you'll see at the base of those ectopic crypts, they have proliferation. So they really are little ectopic crypts growing within the polyp itself. So that's a traditional serrated adenoma. So why do we fuss about these things? Well, these are the pathways of serrated malignancy, okay? This is an old paper, but it's still quite useful. It's showing you basically this sort of concept of going from normal mucosa to a hyperplastic polyp or hyperplastic polyp-like lesion to then getting a sessile serrated lesion, as they're now called, to getting a sessile serrated lesion with dysplasia to end up with a serrated adenocarcinoma. And that pathway from normal mucosa through the sessile serrated lesion is thought to go via BRAF mutation. And then following that, you get hypermethylation of the MLH1 gene. So you get out a mismatch repair pathway. You get an MSI high or mismatch repair deficient tumor. If we look at the traditional serrated pathway, so this is a pathway going through the traditional serrated adenoma, much, much rarer. They go through KRAS mutations. So KRAS, say hyperplastic polyp, then a KRAS mutation, then a traditional serrated adenoma, ended up with a serrated adenocarcinoma. These tend to be, so the traditional serrated pathway tends to have microsatellite stable tumors, whereas the sessile serrated lesion pathway tends to go through MLH1 hypermethylation, remote hypermethylation, and so they're mismatch repair deficient. And this is the serrated morphology we're talking about. So when you talk about serration, you're talking about this sort of appearance of frilliness of the surface of the epithelium. In the old days, we used to describe this as like a paper doily. But my grandmother used to have doilies, but I suspect most people haven't seen a doily these days. So these are all the polyps you can get with serrated morphology. We've got hyperplastic polyp. We've got sessile serrated lesion I mentioned. We've got traditional serrated adenoma. Then we have a few other types of polyp that can be serrated, just to cause confusion. The classical mixed hyperplastic adenomatous polyp. Now, most of those are probably actually now sessile serrated lesions with dysplasia, although we do see some mixed hyperplastic adenomatous polyps, very, very rare. Some adenomas can show a serrated type morphology, particularly the more villiform lesions. And other types of polyp or condition can also show epithelial serration, particularly mucosal prolapse and some inflammatory polyps. So don't be an overcall just based on presence of epithelial serration. You need to see all the features. So how good are we with serrated adenomas? Well, to be fair, or serrated lesions, we're not very good at all. This is an old paper now, but what it shows basically is that the kappa score of 4.9, the 5 pathologists listed on that paper, we couldn't really tell very, very reproducibly between different types of serrated polyp. I think we've got better since this paper was written, but it still can be quite difficult. The really important thing is whether there's dysplasia there. So why all the fuss? Well, as we've seen, sessile serrated lesions are associated with advanced, well, can be associated with advanced colorectal cancer. So they're a bit of a marker for tumors elsewhere, although saying that this was early literature, and again, we're seeing so many more sessile serrated lesions these days that they're very, very common. They're being picked up by the endoscopist. And probably the most important thing to be aware of now is if you've got a patient with multiple sessile or serrated polyps, it raises the possibility of the inherited condition, serrated polyposis. And those patients do have a much higher risk of developing colorectal cancer. So these days, sessile serrated lesions, we're much less worried about until they get dysplasia. And when they get dysplasia, they tend to develop into adenocarcinoma quite quickly. Quickly touching on serrated polyposis. Serrated polyposis, WHO criteria there, which I'm not going to go through, but they're quite complicated. But basically, it depends on the number of polyps you have. And as far as serrated polyps go, these can be adenomatous polyps, sessile serrated lesions, or traditional serrated polyps, adenomas. And you often get a mixture of all those different three types. And there's the criteria there at the top. If you've got serrated polyposis, you've got something like a 50% lifetime chance of getting colorectal cancer. The inheritance is still not really understood. It's probably multiple genes causing different similar syndromes, but if you've got serrated polyposis, you have a risk of having synchronous and metachronous carcinomas. So an important diagnosis to make. Okay, just finishing off the other types of polyp. Here we're looking at an inflammatory type polyp. Important to point out, this is not really one thing, it's a mix, it's sort of a bag of different types of polyp. They're an endpoint of inflammatory processes in the bowel. Up until recently, they've always been considered to be sporadic, so not neoplastic. But in actual fact, there's a big overlap with some hamartomatous polyps. And of course, the hamartomatous polyps are probably now mostly neoplastic because we know they're related to hamartomatous polyp syndromes and to gene mutations. So the vast majority of inflammatory polyps will be non-neoplastic and will not be at a risk of developing dysplasia or malignancy. The classical microscopic features you look for an inflammatory type stroma, often some ulceration, granulation tissue formation, and they may have dilated glands. So generally speaking, they're not considered to be associated with dysplasia, but there are a few overlaps. So for example, an inflammatory polyp of juvenile type, that's the polyp in the bottom, the lowest panel there. These are quite common, sporadic. On the background of juvenile polyposis, which is a hamartomatous polyp syndrome, the patients do go on to get colorectal cancer and they get dysplasia within their polyps. So you can get dysplasia in inflammatory polyps in some types, but it is rare. Generally speaking, inflammatory polyps are considered to be benign. The other thing to mention here is we've got at the top what's actually really an inflammatory pseudopolyp, because what you can see is the mucosa is left and there's ulceration on both sides. So you've effectively got an island of mucosa left within a sort of sea of ulceration. That's an inflammatory pseudopolyp. That's what you classically see in conditions like ulcerative colitis. Whereas in the middle panel, that's much more like an inflammatory polyp just arising on its own. And I said the bottom panel is inflammatory polyp of juvenile type. We see those sporadically a lot, but when you do see them as with patients with multiple juvenile polyps, they may have juvenile polyposis, which is a precancerous polyposis syndrome. So mucosal lymoma, we very rarely used to see these in the old days. They were before the bowel cancer screening program in the UK. I think I'd seen 2 of these, and I see them probably 2 or 3 times a month now. What do you look for? They're quite difficult to diagnose at times. If you've got a nice big polyp like the top right-hand panel here, it's quite straightforward. You can see the mucosa looks normal, and the submucosa has a big pink blob of smooth muscle. That's a nice one, but often it's much more difficult than that. Some of the features that help, I think this is quite counterintuitive, but if you look at a mucosal lymoma, what you'll see bands of smooth muscle going up between the crypts overlying it. And that's a really good marker for a mucosal lymoma. You don't see that with normal muscularis mucosae. So benign lesions, usually the problem is they're small in biopsies. Is it lymoma or is it cross-cut muscularis mucosa? The easiest way of looking at that is to do levels, to be honest with you. So do levels if you're not sure. There's something called myocyte disarray where the smooth muscle is all a bit mixed up. I think that's really difficult to assess. But as I mentioned to you, those muscle bundles going up between crypts is a bit of a feature of a mucosal lymoma. It favors mucosal lymoma over cross-cut muscularis mucosae. Now we're getting to much rarer lesions here, and again, these I don't think were ever seen before the bowel cancer screening program in the UK. This is what's called a Schwann cell hamartoma. These are uncommon lesions. They're incidental findings at sigmoidoscopy. They're predominantly in the rectosigmoid. They're very small, 1 to 6 millimeters. And you can see them immunostaining in the bottom panel there. They're S100 positive. Absolutely no association with neurofibromatosis. That's quite important. So these are really an incidental finding, bit of a fascinoma, and they mean nothing clinically at all. What you can see quite nicely, which helps you with diagnosis in that top panel there, is sort of verrucate body formation, like you see in a classical schwannoma, where all the nuclei are lining up. I'll give you a couple more examples there of the S100 at the bottom, just showing you what they look like. So very rare lesions there. Getting on to even rarer lesions here, ganglioneuromas. Again, these are predominantly arise in the colorectum. Usually they're sporadic. The vast majority of these, when you see them, are sporadic. You do see multiple ganglioneuromas or something called ganglioneuromatosis, sort of more diffuse ganglioneuromatous change in Cowden syndrome, in neurofibromatosis 1, and MEN2. So these, usually I would do an immunostain to confirm ganglioneuromas. They will stain they'll stain with S100. S100 will stain the neural and the ganglion cell component. Another very useful stain is calretinin, which stains the ganglion cells very nicely. There have been a couple of cases of ganglioneuromas being overcalled as a diffuse type adenocarcinoma. So if in doubt, I would make sure you do the immunostain to confirm that it really is a ganglioneuroma and not diffuse type cancer in a small biopsy. Most important thing about picking these up really is to pick up the very rare cases of Cowden syndrome, which is another hamartomatous polyposis. Here's some other examples of the staining here. It's just showing you the S100, staining the ganglion cells and the neural cells quite nicely. Just bear in mind, although you don't normally see ganglion cells in the colonic mucosa, you can do. You can occasionally have 1 or 2 ganglion cells in the lamina propria. That does not make the diagnosis of ganglioneuroma. You need to really have a lesion there with multiple ganglion cells and the neural proliferation as well. Okay, moving on, another rare beast here. We now call this fibroblastic polyp of colon. It used to be called perineuroma. What you can see at low power here is you can see the polyp's being bisected, and you can see a sort of serrated type polyp with these pink areas in the middle. If we go at slightly higher power, what you'll see is the pink areas are spindly and hypercellular, and it's that spindly area which is the perineuromatous change. And so fibroblastic polyp of colon really is a polyp showing perineuromatous change. Now, it's interesting because I'll show you in a second, but we now know that this perineuromatous change occurs in a variety of different polyp types, most typically in serrated type polyps. So you'll often see in the background a serrated type polyp with an area of perineuromatous change. The literature suggests that perineuromatous change is of no clinical significance. It's just, again, a bit of a fascinoma. Best stain for it is GLUT1, which you can see in the top right-hand panel, but EMA will show you weak granular cytoplasmic positivity. So fibroblastic polyp of colon, these are rare, slightly more common in females, tend to be in the sort of mid to elderly age group, tend to be in the rectosigmoid. I said to you the best stain is GLUT1 if you can get hold of it. Most people have EMA, but GLUT1 is more difficult to get hold of. You see this perineuromatous change in combination with both hyperplastic polyps, SSL, so sessile serrated lesions, and with adenomas. This is an old paper here, but I actually think you see it more commonly in SSLs these days, as we're taking more SSLs out. This paper from the Leith group here did show that there are BRAF mutations commonly in fibroblastic polyps of colon, but actually the BRAF mutation is normally in the epithelium. So it's actually the background SSL which is giving you that mutation. And the perineuromatous change is non-neoplastic, or I haven't demonstrated any mutations in that. So it's some sort of funny reactive change of no clinical significance, but a bit of a fascinoma. Right, moving on to juvenile polyps. I've mentioned these already. These are a form of inflammatory polyp, and the solitary ones are quite common. You see them in up to 2% of children. And morphologically, you really cannot tell a proper juvenile hamartomatous polyp from an inflammatory polyp of juvenile type. You can't do that diagnostically. So it's really about how many polyps. If you see a kid with 3 of these things, you start to worry. A child with 1 inflammatory polyp of juvenile type is not something to worry about. It's just when you've got multiple juvenile type polyps. You'll see they tend to be very ulcerated. You'll see in the left-hand column at the bottom there, these cystically dilated glands and a very inflammatory stroma. So juvenile polyposis used to be considered a totally harmless hamartomatous polyp syndrome. There's WHO criteria. You've got to have more than 5 juvenile polyps in the colorectum, or juvenile polyps throughout the GI tract, or a juvenile polyp and a family history of juvenile polyposis. We now know in juvenile polyposis, these polyps are due to mutations in the SMAD4 and BMPR1A pathway. Those are all transforming growth factor beta signaling pathways. And this is really a very nasty syndrome, actually. With juvenile polyposis, the patients have a sort of 40 to 50% lifetime risk of getting colorectal cancer. And they often get their cancers in their 20s and 30s, so very, very young. So it's a very nasty polyposis syndrome, but the morphology does overlap with sporadic juvenile type inflammatory polyps, which are considered to be of no risk whatsoever. brings on to the next type of hematomatous polyp syndrome, Peutz-Jeghers polyps. They have this classic combination of hyperplastic mucosa, which you can see in the bottom panels there, and this so-called arborizing network of smooth muscle. So it's meant to look like the branches of a tree. You have a sort of a branch of smooth muscle with lots of hyperplastic leaves on top. When you see them, they're quite classical. Now, people still argue about whether you can get sporadic Peutz-Jeghers polyps. In the literature, it would suggest that actually the vast majority of patients with a Peutz-Jeghers type polyp probably have Peutz-Jeghers syndrome, or at least are at a higher risk of various cancers. So it is quite an important diagnosis to make. I've mentioned the arborizing architecture. You can see that nicely in those two bottom panels with these sort of branches of smooth muscle. Here we've got Peutz-Jeghers syndrome, autosomal dominant inheritance. We know the gene for most of it, LKB13. If you've got a Peutz-Jeghers syndrome, you've got a 40% lifetime chance of having colorectal cancer and 93% risk of developing some sort of malignancy by the age of 65. So again, this what used to be considered when I was a medical student a nice benign polyp syndrome is now considered a nasty cancer syndrome. And you can see they get tumours in all sorts of places. They get carcinomas of the colorectal pancreas, stomach, small intestine, esophagus. They get breast, ovary, endometrial and lung cancers. They get melanoma and they get sex cord tumours. So if you make a diagnosis of Peutz-Jeghers syndrome, these patients undergo really intensive screening. So a nasty syndrome, I said, people have described sporadic Peutz-Jeghers syndrome, but I think the one paper out there that's looked at a big American paper looking at sporadic Peutz-Jeghers polyps found that the patients with sporadic Peutz-Jeghers polyps actually had a higher risk of cancer elsewhere, and there may well be what's called a form fruste, or a very mild form of Peutz-Jeghers syndrome. And just to finish off now, we're going to talk about adenomas versus hyperplastic polyps. How do you diagnose the split those two conditions up? Often it's very, very obvious. I've shown you these pictures before. This is a hyperplastic polyp, and that's obviously an adenomatous polyp. So straightforward. So what am I talking about? I'm talking, so we're going to talk a little bit about how these things develop. I'll show you some examples of where it can be difficult. So there's two different theories of how adenomas develop. One is called the bottom-up theory, and one is called the top-down theory. The bottom-up theory suggests that you get a mutation at the base of a crypt, and that mutation colonizes the crypt, and then you get the adenoma growing out of a single crypt. The top-down theory suggests that you get a mutation in the surface epithelium, and that grows down into the crypt. Now, most of us actually these days believe in the left-hand panel, the bottom-up model of adenoma growth, probably because the stem cells tend to last longer around the base of the crypt. But we know that actually, as adenomas grow bigger, they also show top-down growth as well. So this is an example actually from the small intestine of a patient with familial adenomatous polyposis. And what you can see is that crypt in the middle is a dysplastic crypt. And that's showing you bottom-up growth of a very, very early tuber adenoma in a patient with FAP. That's the earliest sort of thing you get. This is what you actually see in macroscopic polyps that the endoscopist removed. And we tend to see a lot more of so-called top-down spread. And you'll see that here, where you've got normal-looking crypt bases with dysplastic mucosa on top. And that can be really helpful when you're looking, is it an adenoma or not? When you've got that very sharp cutoff between dysplastic epithelium, which you can see in the middle panel there, and the normal colonic epithelium below. That sharp cutoff you can see in several of these crypts is very, very helpful to say this is dysplastic, not reactive. Okay, so where is the problem? Well, this is the sort of thing we have problems with. 3 millimeter rectal polyp, what's this? Is it adenoma or is it hyperplastic polyp? The endoscopist here has burnt this with diathermy. For me, I'm quite an experienced GI pathologist. I would say on that morphology, it looks like an adenoma. But the important thing here is the atypia is on the surface of the polyp and not down deep. So when you're looking for whether it's just in these sort of fried biopsies, you need to look at the crypt bases. And if the crypt bases are normal, it's probably adenoma. And if the crypt bases look a bit hyperchromatic, where the surface is not looking hyperchromatic, it's probably a hyperplastic polyp. Here's another example of something, a 34-year-old patient with a 3 millimeter transverse colon polyp. What's this? Can anyone tell me? Well, the answer is I don't know on those biopsies there. If in doubt, the first thing to always do is get levels. There are the levels on that polyp, and you can see now we've got nice adenomatous epithelium on the surface, tubular adenoma with low-grade dysplasia. And that is the end of the talk. And I think probably a good time to stop, isn't it, Richard, for questions?
I think that's a good time to stop. Yeah, that was really excellent. I think in particular the combination of the endoscopic images with the biopsies was very helpful. You don't often see that in GI talks. Are there any questions from the audience? I think Charlie, you'll have to mute people.
Yeah, I'm ready to unmute if anyone wants to raise their
Yeah.
hand.
So, has anyone got any questions for Professor Novelli? No. Okay. Well, I'll kick off with some questions. What do you think is the most common error, diagnostic error that people make in assessing colonic polyps? Because obviously there's a lot of them that can be possibly confused with each other. What do you think is what's the most like the common mistake that people need to try and avoid?
Well, to be honest with you, I think probably that one of the issues we have is I think we feel obliged to make a diagnosis. We're a bit anal pathologists. We all think
Yeah.
we should get it right. And sometimes you just don't know. And I've just realized I dropped a bit of, I couldn't get this talk onto my system, so I sent it in packets basically. And I've missed off the end bit, which was about adenomatous, about epithelial misplacement. And that's probably the area that is most difficult at the moment, is epithelial misplacement in large sigmoid polyps. So benign epithelium which gets twisted into the polyps.
And
Generally
how,
speaking,
what's the sorry, go on, carry on.
So generally speaking, I don't think it matters so much these days because the endoscopy is getting so much better. They actually know what the polyps are themselves from their AI and from their experience. They've got much better views of the polyps now. And whenever I talk at conferences, they'll often tell me, well, my pathologists always get it wrong and I just don't bother telling them anymore. But I know what it is. And whether they're just being a bit arrogant or not, I don't know. But often when you've got something that's a bit fried, it can be difficult. It can be difficult to tell. And this thing, hyperplastic polyp versus SSL in the right colon, is very difficult. I mean, some people I know don't ever call hyperplastic polyp in the right colon anymore.
Okay.
The WHO criteria, WHO is one ectatic crypt base now, eccentric crypt base. So I certainly do. If you've got something that looks like hyperplastic polyp, I'll call it hyperplastic polyp. And particularly because in the old days, of course, we used to always call hyperplastic polyps. And there's that idea that the serrated polyposis pathway goes from hyperplastic polyp through an SSL. So no one really knows what the precursor lesion of the SSL actually is, whether it's a hyperplastic polyp or not. But that's a grey area. But again, the endoscopists are getting so good, they're taking these minute little things off. And to be fair, I wouldn't get too worried about it anymore. 10 years ago,
Okay.
we were really worrying about SSL, and no one gives a monkeys these days about them. What we do care about is SSL with dysplasia, because suddenly you're going from a lesion that's considered to be less risky than an adenoma
Yeah.
to something which is much, much more risky than an adenoma.
And in terms of the endoscopic appearances, so they're obviously getting a lot better, and they can distinguish, between them, the hyperplastics, the SSLs, and so on, and adenomas. But can they distinguish um, between lesions with dysplasia and non-dysplasia, like the SSLs with dysplasia and non-dysplasia endoscopically? Is that possible?
Yes, they think they can, yes. And they do it
Right.
on pit patterns. So there's all the different pit patterns. They certainly think they can. The issue we have again with dysplasia and SSLs, I mean, we're getting quite in depth here now, but there's lots of different types of dysplasia. So you've
Yeah.
got the classical intestinal type dysplasia, which is quite easy for us all to diagnose. And then I think the Germans have described minimal deviation dysplasia, which I think is totally unreproducible. And there's also the traditional serrated type dysplasia within an SSL, which we see sometimes, which people argue whether that's important or not. So it's a really evolving, difficult area of pathology, I think.
Right.
New pathology we never used to see.
Thank you. Are there any other questions from anyone? S- But you don't think there'll ever be a day when the endoscopists will diagnose them without sending the biopsy?
It's happening already.
Yeah. I think you alluded to that with the hyperplastic polyps, didn't you? They're
Yeah,
already
it's
doing that.
happening already big time, and they're going to start going burn, or pull off and drop. That's what they don't want to pay us. They don't want to pay us to do it all. So as
Yeah.
much as we're going to develop AI, which is going to do the diagnosis for us anyway on these things, and there's lots of people doing that at the moment,
Yeah.
me being one of them. What will probably eventually happen, I suspect, or initially will happen, is that things like the bowel cancer screening program, all the polyps will be screened by AI, and all the tubular adenomas of low-grade dysplasia will be sent off to be reported by perhaps an advanced practitioner or just to sign it off, or even just signed off by the computer. And the ones that will come to the pathologist will be the ones that are a little bit odd or don't fit in or got high-grade dysplasia, or the funny rare things I mentioned at the end, which at the moment are very difficult to teach the AI on because they're so
Yeah.
uncommon.
And of course, I suppose in a developing world context, that also applies because AI can run on an app potentially in the future. And so endoscopy can be performed in most places now. And it's probably going to reduce the workload for the pathology laboratories in those resource poor countries and still enable them to undertake a realistic bowel cancer screening program.
Yep. I think it's happening already in places like some of the African countries like Nigeria, they're using it, I think.
Yeah.
Certain endoscopy suites. I mean, I certainly know some of our endoscopies go out to Nigeria and they use their AI when they're out there.
Right.
So it's happening, it's coming. And it'll just mean that we're doing the more difficult things, I guess,
Yeah.
until potentially we're completely replaced if that ever happens. But
Yeah. Well, who knows?
who knows?
Still be something for us to do, I'm sure. Well, thank you very much for that really thorough, comprehensive talk with clinical, macroscopic, endoscopic, and microscopic pictures, and really helpful practical insights as to how to separate them. It has been recorded, so we will be uploading it to the pathology portal in due course, probably next week. Everyone on the line, can you please, let your colleagues know that the talks are still continuing, and I will be talking on hemopath next week. I do that every second week, as you all know, and the week after is renal biopsies with Dr. Anu Riley. So same time next week. And in the meantime, thank you very much, Marco, for your time. Very, very grateful to have your time because I know you're, I'm sure you're in high demand with all your experience. And now I have to go and report some trophine biopsies. So I'll say goodbye to everyone. Yeah, they're much simpler.